Hello and welcome to this online event, looking at embracing innovation and meeting the productivity challenge. I'm Dr. Sonia Wallbank at the King's Fund, and I'm going to be chairing the event today. I'd like to start off the session by thanking our event sponsors. It's held in partnership and has been financially supported by Roche Products Ltd. Thank you. We've got a great panel of speakers today, some real diversity of thinking across our panel. We'll meet them in a moment. I'd like to introduce initially productivity and how this lands, just some initial thoughts that we had. Recognise that this can be a loaded word, certainly at the moment where we've got people doing above and beyond the call of duty. How can we think about this differently? How can we break down the barriers that stop us innovating locally is where we want to go today. Productivity can often be perceived as a negative term. So we want to, again, think about this in a way that enables our staff to really think about their current environments, recognise that despite feeling exhausted, there are some really simple ways that we can start to think differently to be able to do more. How can we do this together? How can we look at the nature of our teams and organisations in a bit of a different way and think about connecting and working together to be able to think about those improvements, and more broadly doing this together as a system. So lots of interesting thoughts on that we've had today. So the event's live. We will include a panel discussion and then respond to question and answers and try and give you a range of space to answer some of your questions today. You should be able to see a Slido box to the right of the video, which is where you can submit your questions, and then please do upvote for those that you're interested in hearing a response to, and we'll aim to answer the most popular ones. We will also be putting some poll questions ready for you, so they'll flash up at various points during the session. Please do participate. And we also encourage you to follow the conversations on Twitter using hashtag KFOnline. Please do look at the resources pages on the left-hand side. There's a menu of options for you to participate in. So whichever way you're looking to participate today, a great conversation for us to start. So if I can introduce our speakers first of all, if I can ask you just to come on and tell us a little bit about who you are. Penny Dash, can I start with you?
Hi everyone, my name's Penny Dash. I'm Chair of North West London Integrated Care System and Integrated Care Board. We are responsible for about 2.3 million people who live in North West London, and our remit is to improve their health, reduce inequalities in health, ensure high quality and efficient services, and drive economic value.
Welcome, Penny, thank you. Rachel Stansfield, coming to you.
Thanks, Sonia, and good afternoon, everyone. I'm Rachel Stanfield, and I'm the Acting Chief People Officer at Oxford University Hospitals NHS Foundation Trust. We're one of the largest teaching trusts in the UK, with almost 13,000 staff, providing more than 1 million patient contacts every year. And we're also part of the Buckinghamshire, Oxfordshire and Berkshire West Integrated Care System, and it's great to be here.
Welcome, Rachel, great to see you here. And hello, Paula Head, coming to you.
Hi, my name's Paula Head and I work for Roche. I'm the Policy Value Access Lead. I have in the past worked for the King's Fund and various roles in the NHS.
Thank you, welcome Paula. So what do we mean by productivity? I think that's a common question that we get asked and probably one that's got a bit of a broader answer. So I just want to take a few minutes for each of you to give us a sense of what you mean by productivity and what you wanted to share with us. So Penny, can I come to you first? Just a couple of minutes, please.
Thank you. So for me, productivity means getting more for the same, or getting more for less, or getting the same for less. And I like the concept of healthcare value, which many people will have heard about, but essentially saying that in any healthcare system, we should be thinking about the value that we deliver, i.e. the degree to which we are improving people's health, improving people's well-being, and reducing inequalities in health, and we should think about the denominator, i.e. how much money do we spend doing that. So for me, productivity is about getting greater value for the money that we put in. And there are two broad types of productivity. The first is allocative productivity or allocative efficiency, which essentially means that we should only spend money on interventions that have an impact on those aspirations, or that we should spend money on the things that deliver the most value or the most impact. So that could be anything from thinking through how do we reduce unnecessary and inappropriate antibiotic spending, through to how do we reduce the number of joint replacements that we do on people that won't make a difference, either because it's the wrong type of care, they would be better with physiotherapy, or because their health status essentially will prevent them from getting the most impact. So that's allocative productivity or allocative efficiency. It's about thinking through what we spend the money on. Technical productivity is essentially saying, how do we ensure that our delivery of any healthcare intervention, but you'd hope it be high impact ones, that our delivery is as low cost or as effective as possible. So that means, for example, looking at how much money we might spend on doing a hip replacement, or how much money we might spend on looking after someone with diabetes. And many people perceive that this is talking purely about staff. And yes, the workforce is the biggest cost element within healthcare delivery, but there are lots of other areas of spend as well. So there's the cost of buildings and equipment, that's around 20% of the spend in the healthcare system. There's the cost of procurement, which is around 10%, or anything between 10 and 20% of the cost of a healthcare system. So it's not just looking at the staff, it's looking at all of those different areas of care, and come on and talk about more examples of where there are opportunities to significantly reduce the unit cost of delivering any healthcare intervention.
Thank you, Penny. And noting some of the, I guess, some of the challenges around these terms, that it feels like we're talking about things that we're not quite comfortable with in that care delivery package. So yes, some honesty and openness, I think, through the conversation is really helpful. Thank you.
So if I could just add, Sonia, the reason why I think we have to talk about this is the biggest lever that we have to open to us as a country to improve health and reduce inequalities in health is productivity, by miles.
Thank you. Really
if we could reduce the unit costs that we spend on healthcare by 0.5%, think of how much money that would be that we could put into interventions that could have an impact.
Yeah, thank you. Rachel, may I come to you next?
Yeah, thank you. So I think it's really important for us to focus on this. We know that we can't continue to deliver care or deliver support functions, for that matter, the same way in the future as we've done in the past. So not only because it's financially unsustainable, but we also know that delivery of the best quality patient care requires us to maximise advancing technologies, and that in turn requires a productive workforce. So I think we've already touched on this. Productivity is often thought of as synonymous with cuts or taking resource away from people. But for me, it's much more about doing the best that we can with the resources that are available. So similar to as Penny's already talked about. And I also think it's a mindset. So recognising that things change, that things can always be better, and that they can always be improved. And as an HR and OD professional, I also think of productivity in the broadest possible sense. So what's the maximum human potential that the workforce represents? And what's the gap between that potential and where we are now? And what can we do to support our people to be their best, work in the most productive way, and harness the solutions and the innovations that we know that they can contribute? So I think that productivity is intrinsically linked to our people, to our employee experience, and to our culture.
Thanks, Rachel. I was mindful of, as we return back from the pandemic, our overall human productivity feels like it's taken a real hit. People are exhausted. And so really recognising that we're just not as productive, certainly in the non-paid space, perhaps you know the what we're actually doing during the day feels a lot less than it was probably prior to the pandemic. Thank you. Paula, can I come to you?
Yeah, I mean, we're just getting to grips with this as an industry. We know we've got a role, and it might include the way that we interact with the NHS, but it will really help us to understand more what it means to the NHS so that we can have that partnership dialogue that's going to be really important. And we were working on this yesterday, and we were choosing to understand from our perspective what it's not. It's always easier to start that way. And what we think it's not is a reduction in price, because things that are cheaper aren't always more productive. We think it's not also always buying additional capacity, and it's not always hard quant cash releasing or money related. We spent some time recognizing that point. I think Rachel and Penny have both made really well, which is that sometimes the productivity benefit will be felt by the people who work in it. And that might be as little as having time to breathe, getting a cup of tea, whatever it is, but a better experience for the clinicians, better experience for the people working in the NHS, ultimately a better experience for patients. And we also thought that it isn't formulaic. It depends very much on local circumstances and how local services are delivered. So then we did spend a little time trying to think of what it might be, which is much harder, of course. But we thought that it might be important that it's sustainable, that it needs to be able to carry on into the future. You can't put something in place, gain the productivity, and then lose it. So it's important. It needed to be measured, but that was for two reasons, really. One is to obviously assess the impact and recognise a productivity gain, but also to be able to collect evidence about what works so it can become scalable, which is the other thing we thought was important. And most important of all, and something that Penny said right at the beginning, focused on improving quality for people and outcomes. So that has to be the central tenet. And when we work on the what, we also consider the how. And we thought that it was important to spend time on the rationale. So why are you going in to support this productivity? What are you looking to gain from it? And then be clear about the benefits and how and where they'll fall and to who. Resource it appropriately. Sometimes, you know, you're looking for real opportunity benefit and find that somebody's trying to do it on top of their 10 other things, and it doesn't land and you don't get the benefits you're looking for. And then most importantly, probably spend time on the relationships will make this successful. And because it'll be the relationships along the pathway in the working environment that really make this happen. And then from an industry perspective, if we get that right, then it should hit the ABPI recommended sweet spot of good for patients or people. And I'd re-emphasise the importance of the clinical workforce in that, good for the system and good for the company that's working with you.
Thank you, Paula. I mean, so helpful to recognise that something is absolutely good for staff and really wanting to pay attention to that, but ultimately that will involve it being good for the patients. So yeah, hugely important. Penny, I know that people are excited, given your contribution to the Hewitt review, to hear from you. I guess I wanted to start with, do you have any reflections from that work? I guess more widely as an ICS, around the potential of improved productivity, particularly on reducing inequalities and supporting improved staff welfare?
So thank you. I mean, essentially, as I said before, I think this is the biggest lever by miles. And it doesn't always feel like that. But if we sort of step back for a moment and start to think of where the NHS budget, whatever it is at the moment, 180 billion or whatever, where that is spent, and then start to think through, well, do we spend every pound of that effectively? We know we don't. And I've got lots and lots of examples from the completely mundane, like the £1 million a year some hospitals spend on stamps, unbelievably, through to examples about looking at ways of working, the time spent by staff looking for notes in an outpatient clinic, the time lost in our diagnostics because we haven't scheduled it perhaps as well as we could, or we didn't do as good a job of communicating with patients and so on, so we end up with empty slots, or the space that isn't very efficiently used in many of our buildings. So many of our, much of our space across all of our buildings, of course the NHS has an enormous footprint, and even bigger if you add local authority to that. And yet much of the space is quite empty at 5 in the evening, or 6 in the evening, or 7 in the evening, or at the weekends. And so we end up with, out of 168 hours a week, I'm not saying, we're going to be providing all services 24 hours a day, 7 days a week, but even if we provided services 12 hours a day, 6 days a week, that would have a significant impact on that 25-30 billion pounds that we spend on our physical assets. Just think about that. Nothing to do with staffing numbers and so on. So if we could improve the use of space by just 10%, I think we could do it by well over 50%. But let's be modest. Let's start with 10%. The amount of money that would free up, that we could then spend on better housing, better food, better primary care, you name it, things that we know would have a real impact on people's health and on reducing inequalities. Wouldn't that be amazing? And why do we, who cares about bricks and mortar? What we should really care about is people's health.
And interesting, Penny, how we often go for the more challenging solutions when we're trying to fix things, and perhaps walk by stuff that could be really useful.
Exactly.
Rachel, how's Oxford thinking differently? I guess especially at a time when we're facing challenging stresses in the workforce. I know you've got some really nice examples about engaging and empowering your particular workforce and certainly supporting their well-being, which would be gratefully received. Tell us a bit more.
Yeah, so the sector is obviously facing enormous challenges, most obviously around elective recovery, industrial action, and the changes that have been brought about by the pandemic. So we have had to think differently about how we ask the workforce to deliver given these pressures. I think the first thing to emphasise, and something that was really a positive thing to come out of the pandemic, is the recognition that the well-being of the workforce is the cornerstone of how we deliver care and deliver productivity, and it's got to be paramount. It's no good asking our staff to meet the productivity challenge without first meeting their basic well-being needs. So at OUH, we've really made sure that the well-being of our staff is front and centre. And that starts with really strong and visible board level leadership and ownership. And I would say we've got an absolute commitment there. Importantly, we recognise all the different dimensions of well-being. So whether that's physical, emotional and psychological, financial, environmental, and maybe most importantly, feelings of belonging. It's been great to get feedback from our staff that well-being is an area where they feel that we have made a tangible difference. So, for example, we've developed a range of cost of living support initiatives, including subsidised travel and transport, free breakfasts, and most recently, free sanitary products. And we also have a unique psychological medicine service for staff at OUH, which has had a real impact on reducing staff absence related to mental health. And we've also invested capital monies in wellbeing equipment such as sleep pods. So all of this is vital to supporting productivity, which is not to say that we don't have difficult choices to make, for example, in how we utilise our capital allocation. But the voice for staff support and wellbeing is definitely making itself heard at the table, which I don't think it always was in the past. And supporting wellbeing is part of our wider organisational people plan, which is our wider approach to engaging and empowering our workforce. And another key approach within this, and still very much with an eye on supporting productivity, is our work to strengthen the culture and embed our values. So we're working to embed a culture where everyone feels they belong and everyone feels they can contribute. And firstly, we talk about kindness, civility, and respect. And this is most importantly a question of values, but we know from the work of Dr. Chris Turner, Michael West, and others that incivility and bullying and harassment have a direct impact on patients and staff in terms of harm. And we know that there's productivity loss in relation to those things. For example, higher turnover and higher absence rates and lower morale. So we see kindness and respect not as nice to haves, but as an essential foundation for all of us to perform at our best and to work as productively as we can. And again, like the wellbeing agenda, that's not a side issue for the HR team, but a top priority for all our leaders. And it's led very visibly and very personally from the top by our chief executive. All of our staff have got access to training in that, and that's actually something we've done as a system. A key challenge is how we support them and free them up to do that. And we have to recognise and be responsive to the competing pressures that they face. And I think sort of finally, I'd say equality, diversity and inclusion are also key. So we know that we continue to have staff who don't share that sense of belonging and who don't feel they can contribute their ideas. And as long as that persists, our workforce won't be as collaborative, innovative and productive as it could be. So that's complex cultural work, and it requires a deep understanding of the impact of, for example, how all kinds of discrimination operate and how they deprive us of talent, as well as deprive individuals of their sense of well-being. Staff networks are part of the answer to that, and we're doing work to build the capability of ours, but we've got a number of other objectives that are aimed at strengthening our focus on inequality. So health and well-being, culture and values, EDI, I think they've sort of been seen as add-ons in the past, but we're really thinking differently now. They lead to lower turnover, lower sickness absence, higher levels of engagement, all of which can be quantified in productivity terms.
It's so exciting, Rachel, to hear you talk about some of those basics that were very present and visible during the pandemic, but actually key to that workforce development moving forward in the future and at the kind of core of what an NHS staff offer can look like. I really want to hear some more. Paula, what do you think? You've told us a little bit about improving productivity and certainly the Roche approach. Just tell us a bit more about improvements from your perspective.
I think innovation's got a really important part to play in productivity and the introduction of innovation. And I remember when I first started at Roche, I had to do a presentation to the board who'd come over from Switzerland, which was a bit of a shock in the first couple of weeks. But what I did is put a challenge in front of them that was essentially to say that the drug alone can no longer be the innovation. It doesn't mean there aren't some phenomenal drug developments coming. However, a lot of these developments need to be and are being considered alongside other innovations such as digital. And it's important that we do that. But also, I think it means that, as I mentioned before, that pharma's got to rethink its perception of innovation and its application into the NHS, right from trial design. And I was really interested to hear Rachel talk about equality, diversity, inclusion. As we know, quite a lot of trial design doesn't really meet the needs of the people who are going to benefit ultimately from the innovation. And it needs to be, the industry needs to reflect on how it improves the involvement of everybody in clinical trials and what the implications of that for supporting EDI and inequalities in the NHS. And we need to think about that right from, I say, trial design to application in the system. And at all points, thinking differently about patient relevant benefits and kind of avoiding the Me Too approach, the health system value and the scientific differentiation, but with those two things in mind. What are the patient benefits? What's the value to the system? And I think there are two parts to this. One is the industry thinking about where innovation's needed for transformation. So matching the innovation to the needs of a health and care system. And that's across the world, where across the world, pretty much everybody is facing the same challenges. And then make sure that it's implemented conscientiously and carefully, because one of the biggest challenges I can see in taking benefit from the innovation support for productivity is that NHS transformation isn't keeping pace with innovations. And so we've got to work together to make sure that the NHS can take the opportunities that it gives. And by doing that, by having a shared purpose, like we saw in COVID, where suddenly innovation application was really quite exciting, but that was because we had a shared purpose. Having a common culture for innovation and an honest dialogue about jointly targeting investments and incentives, and that for the industry and for the NHS may lead to flexible and innovative pricing and contracting and commissioning, and a real agreement about what value represents, which I think Penny picked up right at the beginning. You know, what is value in the NHS? How do we, as the industry, start to find and be able to deliver that value, which is beyond the clinical effectiveness that the product brings. So I think there's a great opportunity for the industry and the NHS to work together, both at a national level, but also on the ground.
Yeah, you give that real sense, Paula, from your experiences of the hope and the art of the possibility. I think there's a real energy about the way that you talk about this topic that I don't know about you, but sometimes feels lacking in services, just because of how people are, you know, exhausted. And I can see some of the questions that are coming through are, you know, how do we get better at this? So it's refreshing. I think we probably need to focus more on that. So,
I think there was, sorry. I was just going to say that actually, I think you're right. And there is something about us looking for productivity in the here and now, and addressing the issues that are facing everybody in the NHS, and also making sure we've got space, time and opportunity to focus on the future, if that's possible, because that way, hopefully, we'll get ahead of the curve and solve some of the problems downstream, make life easier when they become today's problems.
Exactly. Yeah, thank you. So we're obviously focusing on some of the challenges that we're facing. So we've got all of this art of the possible when it comes to talking about productivity, but how do we translate that? How do we look at that culture of innovation and really move this forward? Rachel, can I come to you? Because I know that you've got some examples of some QI work that you'd started to implement, and I know people will be really interested in what are some of the challenges and bumps in the road you've experienced.
Yeah, sure. So I think, you know, productivity is clearly a significant challenge, as we've said, and it's a concept that can create antibodies. I think one thing that's helped us is taking a structured and transparent approach. So we have a productivity committee chaired by the chief executive and attended by our senior clinical and corporate leaders. And the areas of focus are clear. So, for example, we track length of stay, theatre utilisation, staff turnover, staff sickness, and so on. And we triangulate our operational and our financial data. So we've got a shared understanding about the relationship between the two. And that gives us clear metrics and KPIs that we can monitor and that tell us what's going on, where we're seeing an impact or maybe where we're not. And we also use statistical process control, so SPC tools as standard, to understand trends and variation and to guide our actions. So over the last financial year, we started to work on these metrics and improve our shared understanding of what needs to improve and how we do this. And we've managed to create 37 million in efficiencies without any impact on quality, and reduced our deficit run rate, and our turnover and sickness levels have also reduced over the last 6 months. But I did want to talk about the importance of QI, as this approach to change and innovation is key to the productivity challenge. All of our staff have access to quality improvement through our QI hub and our improvement team. The QI Hub is an HSJ award-winning innovation. It's a platform that brings together all the QI activity in the trust and runs QI stand-up sessions to share learning and lessons from this activity. And we've trained over 500 staff in 1 year alone. Our programme of QI activity is monitored through the Productivity Committee that I've mentioned, and focuses on key areas such as cancer improvement, urgent and emergency care, and harm reduction, as well as education and community building. The key to supporting productivity, I think, is aligning QI activity around the organisation's strategy and objectives. So fundamentally, QI is about empowering those with the greatest knowledge of our current processes to innovate and to find solutions. And that includes our patients as well as our staff. This year, we saw positive shifts over and above the average in our staff survey results for questions relating to staff feeling able to make suggestions to improve the work of their team and in feeling involved in changes that affect their work. So those are small but encouraging signs for us to build on in creating a culture where people feel they have autonomy and control, which are vital for engagement and innovation. One example probably that I know best is in relation to recruitment, where we've taken a QI approach and listened to the experience of our staff and our candidates. And by streamlining our approach and leveraging the technology we have available, we've been able to take around 14 days off our time to hire a new recruit. So this helps with productivity, sort of most obviously and perhaps most quantifiably by reducing the need for temporary staffing. But it also supports productivity in the wider sense because it frees up our managers' time and their energy to focus on other things. Not that I'd want to portray an image of perfection, and it's also really important to recognise that productivity is an ongoing endeavour. It's not just that we do it once and that's it. It needs continual review, measurement and adjustments. And I think we couldn't talk about productivity and innovation and not talk about the role of digital and particularly support for agile and remote working and the role of automated solutions and AI. And we've got a really strong focus on digital at OUH, and we take care to link that into our productivity work streams in relation to outpatients, as well as link it to our QI approach. And to support innovation, we also have The Hill at OUH, which is an active digital innovation platform that enables bottom-up innovation. So we actively promote engagement from all staff in these opportunities. So there are plenty of ways for them to get involved in the productivity and innovation challenge.
Well, thanks, Rachel. There's some really good, strong examples there from an organisation that's clearly looking at this as a collective. Penny, I know that you've been doing some work certainly to enable your teams to look at the world differently and focus on where they need to make those improvements. Can you give us some examples? Yeah,
absolutely. So, and also I wanted to, as part of that, I'll touch on, you said, what are some of the things that get in the way? And I think we should be, very open about that. So I think the first I would say is honesty and openness. So we have really sought as an ICB and as an ICS, let's be honest with ourselves, let's be honest with all of the organisations in the patch, let's be honest with our staff, and let's be honest with our population really about where the opportunities are. Because it's very easy to sort of get a bit coy on this topic, everyone, as we've all been saying, it's not often not the most popular thing to bring up. But we've tried to be very open and honest. And that started really by putting a few things on the table. So the first was that the workforce numbers, particularly the clinical workforce numbers in the NHS in North West London and of course across the country have gone up considerably in the last 2 to 3 years, as indeed has the money going into the NHS. And yet the levels of recorded activity have gone down or stayed flat. So there are lots of reasons for that, and Rachel and you have set all of that out, and that's as true here as it is anywhere else in the country. We've got a number of processes that are not working well, particularly length of stay, which I'll come on to in a minute, in hospitals and discharge plans and so on. We've got relatively high levels of attrition and recruitment, and as Rachel just said, it takes a lot of time to recruit people, and it takes time to train them up and get them up to speed and so on and so forth. So there are lots of reasons as to why those numbers are what they are. It's not that people are all sitting outside in the park. They're not. Everyone's at hard, everyone's working really hard, but we are where we are. So our first thing really was to put that on the table. And I think that made a really big difference. And in particular then for us to have a reasonably sort of open book approach amongst all of our providers in the patch. And so what we have as an ICB have been doing is very much working with our providers, where we have put in support, whether it's pieces of analysis or work or supporting things like QI work and so on, to actually say, what are we going to do about this? And a very good example of that would be our operating theatres, where we did very detailed analysis of all 75 operating theatres, what hours they were available for, what hours they were staffed for, and then what hours we were operating. And despite us being one of the most efficient parts of the country, it was quite staggering what was happening. So literally, of fully staffed sessions in theatres, everybody there, everyone ready to go, we were only operating for half of the time that the staff were there. And that, of course, is a lot of value to our residents and our patients, and of course our staff who want to be working. And so now we're working on what do we do about that. That's sort of one. So this concept of honesty, let's put it on the table. We've done similar pieces of analysis in other parts of the sector. So I think that's really the first thing. The second is then really trying to come up with very tangible examples. So that's one example. Some of the other things then, these are positive examples of where we think we can really change. So we have been using some technology. We've been using data and analytics. We have started much of that in our acute hospitals, but we absolutely, it can't stop there. And so we have to take some of these, really quite exciting solutions that are out there and start to think about how do we apply those in other places. So if I just stayed with theatres for a moment, we have been using some really interesting software tools, essentially, or AI, depending on how up that sort of advanced spectrum you go. Many people would call it AI, to work with our surgeons to do smart scheduling of their theatre sessions. So that means looking at where are the patients with the greatest need, where are there inequalities in access to surgery that we need to address, but also what are the most efficient ways of running a theatre list? Do you put all right hips in the same time as all left feet or whatever, of which of course the surgeons are pretty good at knowing that. And we've also taken into account the surgical preferences of the surgical team and so on. And in doing that, we've seen an absolutely step change order of throughput in our theatres. Now, if we need to now take those same tools and start to use them amongst our multidisciplinary primary care teams. We've now got lots and lots of people in the R's roles. We've got paramedics, we've got pharmacists and so on and so forth. It's quite a complicated business to schedule what happens in local care. We're increasingly trying to work more closely with community services, mental health services, social care. We need tools that support us to do really efficient scheduling of those staff, not just in our theatres and so on. So there's some really interesting bits of tech that we could use. And so my sort of second to honesty is let's be really clear about what are the things that we could do that would have an impact. And again, a very good example of that I mentioned earlier, things like we lose a lot of time through poor scheduling in diagnostic equipment and so on. Often the answer has been, right the way through from the government to locally, we need more bits of kit. We need a new CT scan, we need a new MRI scan and so on. We don't. What we need is to use those bits of kit more effectively. And again, AI tools and so on can help us do that. So all of this for me is honesty about where the opportunities are. But in order to do that, in order to capture these, it takes time. And I think I won't go into that. Rachel beautifully articulated. This is a real concerted effort required across organizations, across systems to do things differently. But the final bit, and then I'll stop on that, but I think one of the real sort of both tricky bits, but also opportunities of ICS is around shifting money across different parts of the system. So the real cost of a hospital bed per day for someone who's ready for discharge is probably around £1,000 a day. That's the real cost if we take into account all of the costs. Probably a bit more than that actually, but I'll be sort of cautious in my numbers. £1,000 a day. And if we could take £50 an hour for carers, that's to give them a really good pay, but also to cover the cost of employing them and so on. That's 20 hours of a carer for each person in a hospital bed who doesn't need to be there. And we've got hundreds and hundreds, literally, of people in that situation across Northwest London. But we've got some real challenges in how we make the shifts. No one wants us to take those beds out of our acute hospitals. That's a challenge, and we should be a bit more honest about that, because everyone wants more beds, more beds, more beds. Equally, if we were to shift that money, we would then be shifting that money into social care, and that comes through a different government department. So my three things, honesty, time, and shifts, are both some of the opportunities, but also some of the challenges in this space.
Thank you, Penny. That's hugely helpful to have it in that sense. I'm sort of left, Paula, if you don't mind, going, well, what's the role of industry and the private sector in supporting all of that great work that Penny's outlined? Because that sounds like there's some real opportunities to partner well.
Absolutely right. And a couple of things went through my mind as Penny was speaking. One was the really interesting shift dilemma, which is looking value across pathways. So right from the opportunities that come from screening, earlier diagnosis, all the way through to treatment, and having that oversight. But to go with that, for me, the industry's got quite a lot to offer in terms of the skills that it has. So I've touched on already, not just the what, but the how. So access to health economists, digital and data experts, software platforms, all of those things that can contribute to finding a way through some of the challenges that Penny's put out there. But there's also something for me about the way the NHS works with industry. And it would be great to see if we could get over some of the existing barriers. It was marvellous seeing what happened in COVID, and then slowly the creep back of issues that are quite right and are still kind of getting in the way of partnerships. So, for example, appropriate but not too heavy governance, perhaps a common approach to a framework for working with industry so that we can go in wherever, because of course there's always the opportunity for us to share best practice nationally as well, hearing some of the phenomenal things that are being done both in Oxford and in Northwest London. And model agreements perhaps. But there was another thing that was I was thinking about, reflecting on my own background, which is if you listen to the way that Oxford's approaching productivity, and you think about that as a experienced teaching hospital, used to working with the industry, really confident and competent in its ability to get the best out of that partnership. That's not quite the same potentially in DGHs. So what's the role of the teaching hospitals, the AHSNs, in making sure that they can spread that confidence to other parts of the NHS, and then making sure that we do the same to share what we've learnt works in some places to be able to pass this across the whole country.
Thank you, Paula. That sounds like some great partnership opportunity. So I've got some questions. Thank you very much for all of the information. We've got some real activity in the chat, so I'm going to go through and see if we can reflect on those together. Penny, if you don't mind, I think the first one is probably best directed from yourself. How do you think we can invest in productivity, Seamus asked, through health promotion and prevention of ill health when our finances are largely managed year by year? A popular question I'm sure we've answered before. Thanks, Penny.
Yeah, it's a really good question. So in the Hewitt review, I think it was very interesting. The biggest thing that people said, whether you spoke to senior managers, senior doctors, you name it, across the system, was we need to move away from one-year budgets, and we need to move to 5-year budgets, if not 10-year budgets. And I would add to that we also need a bit more latitude locally, because we have very, very, very little latitude locally. I didn't realise that actually, but we do. So I think we have to work within those constraints. We keep campaigning that we do move to have more latitude and longer term visibility. But in the meantime, I still think there's lots we can do. So we absolutely need a very different model of primary care and local care. That is, we know that what happens in primary care is highly impactful in terms of managing various long-term conditions, and indeed of sending out very positive reinforcing messages about health behaviours. So we absolutely need models of primary care, local care, where we are able to spend time on looking after people with long-term conditions and so on. And so I really like the Fuller review that sets that out, but also sets out, and indeed, again, it was interesting yesterday to hear that in the Labour speech, you know, this possibility of a sort of two-track model. So some people want absolutely efficiency in terms of their own time. They want to see someone very quickly, probably happy with a digital consultation or a rapid in-person consultation in an efficiently run, you know, facility that would allow us to do that. Other people need that management long-term conditions with time and multidisciplinary teams. So that is a really big thing that we've got to get right. The other thing is working with our local authority colleagues to really think about those wider determinants, to think about education, about access to space to exercise, about access to you know, appropriate food, so you can cook healthy food and so on and so forth, as well as things like better housing and so on. So it's those two things that we need to be really, really focused on, and thinking through what does that mean for all communities, not just for the healthy communities who will continue to get healthier if we don't do anything about it.
Great, thank you, Penny. Really comprehensive answer there. Rachel, can I come to you for the next one? So this one talks about if involvement in QI activity and projects supports productivity realisation, how do we engage busy clinicians and staff when they're struggling with their day-to-day services? And specifically a question around what role we think leadership plays.
Yeah, so this is a great question, and I haven't got a silver bullet or a really easy answer to this. We obviously look for ways that we can free people up by giving them time where we can. But I think we need to recognise that people sort of also need to see the importance of it themselves. So, and I think that's where the leadership point comes in. So I think where people really see the benefit of something, where we can make the case and convince them of its importance, then it's easier for them to find the time. But as I say, it's really a difficult one in terms of freeing people up. But I think being clear about priorities, being clear about the importance of things, and listening to people where they think they've got ideas about how we can fit things in, do things differently, whether that's on-demand training or some other idea that people may have. Really kind of listening when they raise their own thoughts about what we're asking them to do.
Thank you, Rachel. Really helpful. Paula, I've got a question which may be easier to answer from your commercial perspective, but when thinking about stopping some of the things that we need to do really to be productive, we often shy away from stopping or reducing things, and I think particularly in the public sector that's very hard to do. How do you think we could encourage this more?
This is something I think that's been a challenge for a long time. Certainly I know in my experience, it was previously like, how can we decommission things? Well, actually, I think that's a huge challenge. How do you stop anything when there's somebody on the end of either a waiting list or a patient intervention that's really important to them? But I think what we've got to learn, what we could learn from the industry, is that I think it's not about stopping things. It's about making sure that there's a understanding and a recognition for the choices that are being made. So, for example, and it's something that we do, is identifying what's going to contribute to an urgency that's going to have to be addressed straight away. And I can think, for example, of if you were kind of putting a long row of people in order in terms of the way that they need to be treated, or could be treated, or could be cared for, or you're choosing your priority, it would be to identify those who have the most imminent need, not necessarily those who can shout the loudest, we've already heard about that, but also those who could contribute to the wider societal benefit as well. So there is something for us about being more sophisticated in our choices, because choices need to be made. As Penny said, we need to be really honest about this. This productivity is needed because there aren't enough resources in the NHS at the moment to treat everybody as we'd like them to be treated.
Yeah, really helpful, Paula. Penny, Rachel, there's another question about doing less total hip replacements, surgical procedures, etc. And I just wondered if either of you had a view about doing less and whether you think there's some choices we can make.
So I'll give a very quick one, then Reg come on. So I think we absolutely do need to, you know, we've spoken about it. In some places we do, and we do, you know, and there are things now that we don't do anymore in the NHS that we used to, you know, in terms of different procedures. The one thing that I would say is that is tiny in terms of, you know, that's the allocative efficiency. It is absolutely, it's important, but technical efficiency dwarfs it. So being able to do a hip replacement more efficiently is far more important than us trying to find the things that perhaps are less value adding, though sometimes it sits more easily with people to talk about the things that are less value adding. So tricky one.
Yeah, thank you, Penny. Rachel, I was thinking from an HR perspective, some of the innovations that you talked about that enable people to do stuff for themselves. Yeah, what stuff have you stopped doing, or do you think that's a good idea?
No, absolutely, and I think as a principle, it's essential. Really, we've got to look at everything we do and consider its value, consider whether we need to do it or not, and consider where it is in the list of priorities. And I suppose the other thing that's relevant is what can we do collaboratively. So what can we scale across the system, and that's something that we'll start thinking about in terms of people services and other things.
Thank you. We've got a question which is an interesting one. Penny, I don't know if you've come across this. So a question about unpaid carers being supported as part of improving productivity. And I'm thinking of the absent voices that really sit across our entire system, where we're not necessarily seeing the impact of the pandemic for them. Do you have any kind of support, advice, stuff that you've done? Particularly around unpaid carers?
So first off is, I know there is stuff happening, but I don't have it immediately to hand, so I couldn't say about what we're doing. Again, though, what I come back to is to support those carers more does not cost a lot of money. And if we could do the things that are costing us literally billions and billions and billions and billions each year a bit more efficiently, which we absolutely know that we can, that would free up the resources to put the support in the places that we need it, like with unpaid carers.
Thank you, Penny. That's really helpful. And Rachel, if I can just come to you, I think for our final question, and recognising we've got lots more, that it's raised a lot of interest today. There's something about, so Jane's asked about how we make sure we're not putting pressure on staff to be resilient, especially at a time when they're been negatively impacted by the systems that they're working in. And I know when we were prepping for today, we had lots of discussions about, are we talking about resilience and productivity versus the kind of staff health and well-being? Just give us a bit of insight into how we give them control to improve their own productivity.
Yeah, so I think you've already heard me talk about QI, equipping them with the skills to look at current processes and put forward what they think should be done to improve processes. I also think there's a really important role for, we talked about leaders, but also line managers. So actually giving line managers the capability and the resource to provide support to their staff. So that's well-being support, but it's also the time to manage and the skills to manage with their teams, so that at a small level and at a very local level, teams and individuals can come together, find solutions and implement them. So, you know, for example, we take a very sort of practical approach to our staff survey, where we give the teams the data, we support them to understand what that's telling them, and then they can come up with their own actions to address the issues that they know then are important to them.
That's really great. Thank you, Rachel. And I'm sure we could go on, but I'm going to give you guys the last minute each to just give us a bit of a summary as to what you've heard today. Penny, can I start with you?
Yep. So I'd say, you know, fantastic opportunities here. Let's grasp them. Let's be positive about them, not see this as a negative. Let's be really positive about the potential to move to a health and care system in the way that we'd like. let's recognise that this requires a lot of time and a lot of effort from people. And I think, you know, the things that Rachel's been talking about, absolutely fundamental, crucial. I'm very inspired by hearing what I've heard today. I might be asking her to come and speak to a few people locally. And then I think, you know, as Paula said, this requires a whole industry focus. We have the solutions across the wider industry. We need to capture them.
Right. And I love the opportunity of that. The more we can do this and share what's going on at a local level, I'm sure the more productive sharing can take place. Paula, can I come to you next?
Yes, there's too much to say really, isn't there? So I was trying desperately to think of the one thing that was really important, and Penny's already said that the opportunity to work with the whole of the health and care sector, including the industry, is really important. But I would re-emphasise the need to look at all parts of the system in terms of the opportunity for productivity. For too long, we've been in silos of let's look for productivity in this space, and then ignored the fact that no part of the NHS is an island. So I'd strengthen that, and I would say once again on behalf of the industry and the NHS, we need to look again at where we come together in this space with different thinking around some of the innovative technologies that are coming through and some of the AI and digital opportunities that are going to be able to support that.
Great, thank you, Paula. Yeah, fantastic. Rachel, last word.
Thank you. So I want to share Penny's sense of positivity about this, that, you know, we can do it. And for me, it's about the link between the culture and productivity. So really focusing on putting our staff at the centre, their well-being, leading with kindness and compassion. And that's the best foundation we can have for productivity and innovation.
Oh, thank you. That's really helpful, Rachel. Thank you, Rachel, Penny and Paul. It's been really insightful to hear your views today. And I know when we first started looking at what felt like this subject, we wanted to approach it with that genuine sense of it's a large challenge, but absolutely one that we need to pay attention to. Thanks again to our speakers, for yourselves, for the question contribution, and for those watching. That's been great. We encourage you to share a link to the event with colleagues who can register, and then you can watch on demand post today's session. Please do navigate to the feedback option in the menu on your left-hand side, and we'll send out a survey link in an email shortly. We really do value your feedback to enable us to continually improve our events. And then finally, once again, thank you to our event sponsors, Roche Products Ltd. So a couple of minutes back so you can have a cup of tea and think about some productive ideas later in the afternoon. Thank you very much.
Thank you.